I can voice over the beginning part. Okay, so can you still see my PowerPoint?
Yes.
Okay, all right. At the beginning, I have kind of a diagram here that talks about, because these are the disorders that we went over in 125. So the thyroid, the anterior pituitary, posterior pituitary, the adrenal cortex disorders, and then we go down to talk about diabetes. Hormones there as well. As people age, so we decrease our antidiuretic hormone, which means that we pee more often, more frequently. It's more dilute. Again, we could have some electrolyte imbalances. The more urine we get rid of, the lower our fluid volume. We're at risk of falls. And then especially if our patients are taking blood pressure medicine as well, increased risk of falls with those patients, greater risk of dehydration. Decreased glucose tolerance. So what that means is it's more difficult to get insulin released and get glucose into the cells. So we start to see things where glucose stays in the blood system longer. We have increased weight, elevated blood glucose, slow wound healing, frequent infections, the signs of type 2, so polydipsia, polyuria, decreased energy level, because that glucose that we have, it takes longer for the body to realize, the pancreas to realize we need insulin released. So it takes longer for it to get to the cells where we need it. And then decreased general metabolism, so that having to do with the thyroid. Less tolerant of cold, decreased appetite, decreased heart rate and blood pressure, constipation, low body temperature. So it doesn't mean that our patient is hyperthyroid, but what it means is as well that those hormones take longer to get where they need to go. And it also takes the hypothalamus longer to realize when we need more or when we need to turn off the stimulation to produce more. Okay. Most patients with endocrine disorders are going to be on hormones for the rest of their life, especially if it is a gland problem. If it is a tumor that they can remove, or if it is related to stopping steroids abruptly and they correct that, then it may not be a problem in the future. But if it's a gland problem that is just not producing the way it should, or recognizing some of those messenger hormones, then they're going to have to take supplemental hormones for the rest of their life, which also means that they have to get blood work done at least yearly for the rest of their life. What we want to teach patients is not only the signs and symptoms of their disorder, but the signs and symptoms of the opposite disorder as well. So if I have hypothyroid and I'm taking levothyroxine to speed it up, I want to know the signs if it's sped up too much, right? So I've got to know both angles of that disorder to be able to recognize if I have a problem. Got some things in red here as well. I know your sheet talks about a hypophosectomy, and so what that is it's removal of a pituitary tumor, and inevitably it can also remove part of the pituitary gland. And so we have to think about the hormones that are directly related to that as a result of this transsphenoidal hypophosectomy. Transsphenoidal means that it's an endoscope. It goes up through the sinuses to remove the tumor that's pressing on the pituitary. We're concerned with our patients, of course, about infection, but our big concern is that we are going into the sinus cavity and right near the brain, and we could potentially have a leak of cerebral spinal fluid. And so we're looking for patients that have clear drainage from their nose. We don't want them to do anything that's going to disturb the suture or to cause pressure on that area. So no bending over, no coughing, no sneezing, no blowing their nose, anything that's going to make your face red. We don't want to do that. And so positioning as well has to do with this as well. We don't want them to lie flat. We want their head of the bed up a little bit.
So does that mean
go ahead.
Precautions basically?
I'm sorry, I didn't hear you.
Hold on. Does that mean that they'll basically be on sinus precautions, like no straws or anything like that?
Yes. Yeah.
So no incentive spirometer, nothing like that at all?
Right.
Okay.
Yeah, and so I've got care here, and so we're going to monitor neurostatus. We're concerned about any potential for bleeding in the brain or injury near the brain. We're going to monitor urine output. We know posterior pituitary has to do with antidiuretic hormone. So we're going to be looking at the electrolytes in the fluid in the blood as well as in urine to see if it is in normal concentration in both of those. We do want to encourage deep breathing. What that means is we want them to get up and walk, but we don't want to increase the pressure in their head. So again, no coughing, blowing nose, sneezing, bending over at the waist, straining. So our patient's probably going to be on a stool softener. We don't want to rupture that incision. So rinsing out their mouth, not using a regular toothbrush, no straws, and then watching for signs of that cerebrospinal leak. So the pad that they'll be under their nose, we're going to watch for saturation of that. We're going to watch for, of course, any signs of bleeding. We're going to be looking in their mouth to look in the back of their throat to see if they have any postnasal drainage in the back of their throat. We're going to be checking things that, again, are regulated by the hypothalamus. So looking for things that could indicate changes in cognition, and then teach them about any hormone replacement medication that they need to take as well. So I've got here with the disorders of posterior pituitary, again, is going to be things like with diabetes insipidus, we could give them vasopressin, and then we said an AGH excess is going to be SIADH. Problems with fluid and electrolyte balance, because we said that if we have SIADH, we're holding on to lots and lots and lots of fluid, and so what we're going to have is fluid that is more fluid than electrolytes. So we could actually show that we have an electrolyte deficiency, and we know it's a fluid problem because there's going to be electrolyte disturbances with more than just one electrolyte. It's going to show in all electrolytes. And then diabetes insipidus, remember, it's very dilute urine. So we're getting rid of the water part and holding on to the electrolytes. So they're going to be elevated. So diabetes insipidus, diluted urine, concentrated blood. Again, we'll look at both of those. We're going to, it's going to lead to polyuria, dehydration, increased sodium levels, increased chloride levels. Patients are going to be very thirsty, so they're going to keep drinking more and more and more because the brain is telling them that they are thirsty. And remember, when we're losing lots and lots of fluid, that's affecting cardiac output. So those patients are going to be tachycardic. They're going to have increased respiratory rate. They're going to have low blood pressure. They're going to get very lightheaded when they change position or stand up. Let me explain this picture. It's kind of a bizarre picture. So the pituitary gland, what is happening with diabetes insipidus is it's turning on the waterworks. At first I was like, is it turning it on or turning it off? It's very, but anyway, maybe it's just me. But it's turning on the waterworks, and so we're peeing a lot. We can replace that with vasopressin, or it's also called DDAVP, and it can result from problems with pituitary gland because it's directly related, and that can also result from surgery in the brain or a head injury or a tumor that's pressing on it. Lots of those things. Signs and symptoms, lots and lots of urine, low specific gravity. So specific gravity is going to be kind of the weight of the urine. Okay, we're going to look at urine and blood. Low osmolarity, again, of the urine, so low concentration, it's very dilute. Hypovolemia, low blood volume on the inside. We're going to be thirsty. We're going to be tachycardic because we have low blood volume, and our blood pressure is going to be low. Okay. Tachycardia, very fast heart rate, pumping the blood around. Blood vessels respond by trying to help by opening up to make the pathway bigger to get through. Okay. Monitor fluids, replace fluids. Okay. Monitor neurostatus because we're talking about sodium. Check vital signs, check mucous membranes, all those signs that the patient's dehydrated. If we think back to fluid and electrolytes, what happens if we lose all that fluid from the vascular system is it's going to start pulling fluid from the cells into the vascular system. So we're losing sodium, but what's going to happen is we're pulling in more potassium into the vascular system from inside the cells. So we're going to show those disturbances. Goals for our patient, again, are going to be to replace fluid volume, to decrease urine output, okay? In doing that, we're going to be helping cardiac output, okay? So that's our big thing is if we don't have fluid, we're not going to get oxygen that's going around to our body to feed it with oxygen, and hence increased respiratory rate, okay? We're going to evaluate by looking at urine output. We're going to look at weight of our patient. We're going to look at electrolytes in the blood as well as the things that we're getting rid of in the urine. Okay. Again, these patients may require lifelong therapy with vasopressin, which is our antidiuretic hormone. SIADH, so low amount of urine, so we're holding on to all that fluid. It's causing a buildup of blood in the body. And what happens is we only can hold so much in the vascular system. We can only hold so much in the cells, so the rest go into those third spaces. And we think about it as edema we can see and ascites, but it also surrounds the lungs and the heart, putting more pressure on it, as well as those bounding pulses and the tachycardia that we see. And water is retained, results in dilutional hyponatremia. Again, more water, same amount of electrolytes, but it doesn't appear to be that way because the fluid is overwhelming it. And it truly is a hyponatremia because if the sodium is spread out in the fluid, it's not getting to where it needs to get in a quick manner. So we're going to see problems resulting from hyponatremia. And so that's neurological things. So the lethargy, headaches, disorientation, seizures, coma, it truly is a fluid overload. Priority goals for this patient, again, are going to be to get rid of fluid, okay? We're having problems with cardiac output with too much fluid as well. I'm tachycardic, I am hypertensive. If I'm tachycardic, then it's squeezing really fast to get the blood around, but it's not waiting to fill up. So I'm not getting that big, good squeeze on it. So getting rid of fluid, I've got to pull it from those third spaces with a diuretic. Monitor kidney function to make sure that when I pull that fluid in that I can get rid of it. And we're monitoring weight again, fluid restriction. Good oral care because we are going to be on a fluid restriction. So those patients, their mouth can get really dry and full of bacteria. We don't want that into the lungs to cause pneumonia or anything like that. Restrict fluid, promote excretion of water, replace any lost sodium. Again, because we're thinking now that if we're going to make them pee a lot, they're going to take electrolytes with them. So monitoring electrolytes. And then when we have an idea about fluid balance, we could replace any missing electrolytes. Okay? Interfering with the action of antidiuretic hormone. Antidiuretic hormone, again, is making us pee a lot. So if it's a tumor or something like that, then we want to make sure that we know that a tumor that's pressing on a gland can cause it to have low producing of hormone or high producing. It could do either one. It could overstimulate it. So again, thinking about what could be causing it. prevent any injuries. Again, these patients are going to have low sodium levels, and we said that could make them lightheaded, confused, falls. And then monitor for increased fluid overload, monitor for neuro changes, look at labs. So labs, we said things like sodium levels, in particular with these patients. And compare them to here, low ADH, high ADH, okay? High urine output, very dilute, low urine output. We're holding on to all that fluid. Hypernatremia, because we're getting rid of the dilute water, we're holding on to the electrolytes, and hyponatremia, because we're holding on to all that water and it's diluting the sodium. Dehydrated, overhydrated, they're both going to be thirsty. And so we think, oh, that's not at the bottom. Both will be thirsty. One, because they are truly becoming dehydrated, and the other because we are restricting their fluids and it's going out of those third spaces. So they're going to be thinking they need to replace that. So keeping their mouth moist, those kind of things is going to be important. And a good education of our patient. If they don't know why they're on a fluid restriction, they're just going to think we're a mean nurse and not bringing them any fluids, and they're going to get up and get it themselves. Or they're going to have their family do it. So I like this picture here. So what is the problem? We have SIADH, dehydration, and diabetes insipidus. SIADH is I'm holding on to too much water. So due to that too much water, my sodium is going to appear low. Serum, the blood, the weight of the blood, the osmolarity of the blood is going to be low, more liquid than the electrolyte part. Urine that's going out, the osmolarity is going to be high. So what I am peeing is going to be very concentrated because I'm holding on to all that fluid. Small amounts, very concentrated. Let's jump to the bottom. Diabetes insipidus. High sodium levels because I'm peeing out all that dilute water. Okay, so if I look at the blood, the serum, it's going to be very concentrated. But on the flip side, the urine is going to be very dilute. So let's hop over to dehydration. Dehydration truly is where we're pulling fluid from inside the cells. So we're going to see some cellular responses. If I'm dehydrated, that means I'm peeing out lots, or I'm losing through sweat or whatever, but it's water and electrolytes in the same concentration. So that's how we can tell, is this a diabetes insipidus or is this a dehydration? Because diabetes insipidus is going to be very dilute. Dehydration is going to be very concentrated. Okay, so I'm going to have high sodium levels because I have little water. Either I'm not taking in enough or I'm losing it in some other way. The serum osmolarity is going to be very concentrated. Okay, so those two are similar to diabetes insipidus, but the urine is going to look different. Very, very concentrated because I don't have a lot of water. And with diabetes insipidus, it's going to be very dilute. So looking at blood is extremely important, but also looking at the urine is going to really clarify the picture for us. Thyroid gland, knowing that dietary intake of protein and iodine are important to producing thyroid hormones. The parathyroid inhibits, the thyroid gland inhibits the release of parathyroid gland. Okay, so thinking about the release of parathyroid gland, parathyroid lowers calcium. So if our thyroid or parathyroid is not functioning well, or if we have to remove part of the thyroid, it's attached to the thyroid. So we're going to have increased calcium levels. And where does that come from? It's pulled from the bones and teeth and storage. And anything that has to do with increased calcium levels is going to affect cardiac function because it is important for muscle contraction. So we're concerned about things like dysrhythmias, cardiac output as well. Here's this kind of a negative feedback loop of the hypothalamus. If our thyroid stimulating hormone, or let's look at the blood. If our blood has low T3 and T4, it's telling the hypothalamus, I need more. So it's going to release the thyroid stimulating hormone. It's going to tell the pituitary, go ahead and send that out. And then the thyroid will receive that and it'll be able to produce more to get into the blood. So if there's a problem with the hypothalamus, the pituitary, or the thyroid, then we are going to not be able to produce thyroid hormone. The problem, or what we look at with a thyroid panel, is saying which one of those is the problem. So again, if it's going to be a hypothalamus or pituitary problem, we're going to see disturbances with thyroid stimulating hormone and with other hormones as well, because they control a lot of things. If it is a thyroid problem, we're going to see problems with T3 and T4. Hyperthyroid is Graves' disease. It's an autoimmune disorder. Hyperthyroid can also be caused by a tumor. It can be caused by pressure on the thyroid, or a tumor or something pressing on the hypothalamus or pituitary. So a number of reasons. Graves' disease just happens to be an autoimmune process that would need lifelong management with medications. So hyperthyroid, hypermetabolism. It's usually in younger women, so we think 20 to 40, where hypo is in 40 to 60. Hyperthyroid, very distinctive problems with increased respiratory rate. We've got tachycardia. We've got problems where insomnia, but they're still tired because they're not getting enough rest. We're going to see some of those problems that show chronic respiratory problems. So we see the clubbed fingers there. And because the heart rate's beating so fast, it again is decreasing the efficiency of the cardiac output. So patients, if they have chronic hyperthyroidism, could have some signs of chronic respiratory problems. Diarrhea, so the GI system is increased. We've got hypertension, weight loss, because they're using more than the body is able to take in. And then we have that exophthalmia as well, the kind of the bulging eyes. Thyroid storm is related to hypo. Okay. Well, I got that there with hyper. No, I'm sorry, hyper. Get myself out of it now. So thyroid storm, life-threatening hyper. Again, everything is speeded up. Okay. Number of causes. Okay. Again, it could be from anything that affects the thyroid, the pituitary, or the hypothalamus. Lab values, we're going to look at that thyroid panel for T3, T4, and TSH. We can do a thyroid scan to look at the thyroid. They can use radioactive iodine to see if the thyroid gland is able to take in that iodine and respond by putting out that T3 and T4. So is it a thyroid problem? Again, dysrhythmias, tachycardia, so we're looking at EKG. Treatment is going to be tapazole, which is a thiurea, and that is to decrease the amount of thyroid hormone that's being released. Okay. Adverse response, or what we're watching for is to make sure that they don't go into now a hypothyroid. Okay, so monitoring is going to be close, but they have to continue to follow up with their physician. Hypo, again, we're looking at T3, T4, TSH. So is it a problem with TSH? Is TSH being stimulated from the hypothalamus, released from the anterior pituitary, but it's not connecting well with the thyroid, so it's not putting out T3 and T4. Okay. If we don't get enough iodine, or it could also be an autoimmune disorder as well. But if we notice that the age is a little bit higher, so we think it says 30 to 60 here, 40 to 60 being with hypo. Everything's slowed down. Our body temperature, our heart rate, our blood pressure, bowels are slowed down, cardiac output, patients can gain weight because their metabolism is slowed down, their ability for the body to break down nutrients and take it in, so it kind of sits there for a longer period of time. There's an intolerance to cold, so hypothyroid is patients that have problems being cold all the time. It's extremely cold. Again, metabolism is slowed down. Okay? And then hyper, very hot all the time. Medication for hypo is levothyroxine. Synthroid is the trade name. And it's increased levels of the T3 and T4 secreted by the thyroid gland. With levothyroxine, you're supposed to take it without antacids or not with other types of things that are going to stimulate stomach acid. So things like iron, other things that are difficult to digest. So usually it's recommended to take in the evening. Our hormones are more active in the evening. Exedema coma is going to be the extreme life-threatening hypothyroid. Again, everything's slowed down to the point of where we have respiratory failure, no cardiac output, hypoglycemia, hypothermia. Interventions are going to be to, again, replace that thyroid hormone to maintain the temperature of the patient, maintain cardiac output, so giving them IV fluids. It could be giving them glucose, monitoring respiratory status. So do they need oxygen? Do they need intubation? And then we've got the adrenal glands. Again, adrenal glands control glucocorticoids, which is cortisol, which are steroids, and then also mineralocorticoids, which are aldosterone, which is going to be our water and sodium, okay, equal amounts, losing dose. Addison's disease, hypofunction, so low aldosterone, low cortisol, okay? Everything's slowed down again, hypoglycemia, low blood pressure, we're losing lots of fluid. So again, we're gonna see that tachycardia, hypotension, weakness, electrolyte disturbances, losing sodium. We're pulling fluids out of the cells, so it increases our potassium, the potential for our potassium. With these patients, we would need to supplement and give them those steroids and give them aldosterone. This is talking about the steroid therapy that we need to make sure that our patients that are taking steroids, which are a multitude of things, that if they are taking high dose steroids, so we sometimes think about steroids as like a nose spray or an inhaler or something like that, and those are more local, but with this we think about things that are more systemic. So if we're taking oral steroids, that's usually why we're on tapered doses when we take them, is to decrease that amount, and so that the hypothalamus can start to indicate that our levels are going down and to start to produce more. Multiple different types of steroids. Just knowing that what really qualifies is going to be high dose and longer term. And lots of reasons people take steroids. Steroids elevate white blood cells, they elevate glucose, we use up all our white blood cells, so we're at risk of infection, wounds not healing, again, problems related to hyperglycemia, hypertension, stress ulcers, because speeding up also that increases our stomach acid with that. And remember, if we are taking those steroids and we take too much, we could also have Cushing's. So, an altered level of those steroids. Hyperfunction, hypercortisol is Cushing's, hyperaldosterone, cons. I just put in here kind of the difference between Cushing's disease and Cushing's syndrome. Cushing's disease is more what we think about as being something that's long-lasting, and then Cushing's syndrome are usually related to those things like abruptly stopping steroids, and so it causes us to go into this Cushing's. But if we if we correct that imbalance, then the patient should no longer have that hormone imbalance. Again, problems with the adrenal gland, problems with the pituitary, problems with the hypothalamus. Cushing's, we're going to see holding on to fluid, holding on our fat stores. We're going to see, again, things related to hyperglycemia, increased risk of infection. We're going to have, again, related to hyperglycemia, is that the muscles are going to be thinner. If we don't feed the muscles, we don't get that glucose into the muscles, then they start to atrophy and become really skinny. So you have this guy with lots of fluid on his belly, a big round belly, and little skinny arms and legs. So we want to make sure that we teach patients to take their steroids, and then they may have to have surgery if it's something like a tumor that's pushing on the pituitary or the adrenal glands. Okay, let's talk a little bit about diabetes. So type 1 and type 2. Type 1 occurs at a younger age. Okay? It is going to be autoimmune disorder where the pancreas is no longer able to produce insulin. So these patients are going to be insulin dependent. We usually see it at a young age, so anywhere from 10 to 20. And then type 2 is progressive. It's where the pancreas is less likely to be able to produce adequate amounts of insulin over time. And so it occurs over time. Both of them have to do with problems with the beta cells. Type 1 is that the beta cells are destroyed, and then type 2 is they are decrease in functioning. Again, this picture shows that the pancreas, if we have high blood sugar, it stimulates the pancreas to produce insulin. Insulin goes to the tissues. It opens up to allow blood sugar to come into the cells. And then what we have left over of the insulin is going to stimulate the liver to take in that excess glucose and store it. And if our blood sugar is low, what's going to happen is it's going to promote glucagon to be released from the pancreas. Glucagon, again, is going to be a protein that stimulates the liver to release that glucogen, that glucose that's turned into glucogen. And so we're going to release some of that that's stored in the liver to help to increase the blood sugar. And that's a normal functioning pancreas and liver that are working hand in hand together. So we got to have a healthy pancreas, we got to have a healthy liver. If I have pancreatitis, I'm going to have blood sugar issues. If I have problems with my liver, then I'm going to have problems with glucose control and control of insulin. Okay, type 1, polyuria, polydipsia, and polyphagia. Again, this is going to occur very abruptly because it is where the body has destroyed those beta cells. So we're going to see more severe symptoms in a patient that has a diagnosis of type 1 because it is going to, again, result in the results of this polyuria, polydipsia, polyphagia. So polyuria, they're going to be peeing a lot. We're going to see some signs of dehydration. Patients are many times confused, increased thirst and hunger. And if we think about it at a younger age, kids aren't really aware of those symptoms that something's wrong, so they're just going to compensate. We may see them drinking a whole lot or eating a lot or saying I got to pee a lot, those type of things. It could be an infection, so increased risk of infection as well with these patients because they're going to be hyperglycemic. Back up. One important indicator of diabetes type 1 is you are never going to see a person with diabetes type 1 on an initial diagnosis that's hypoglycemic. Okay, they won't be hypoglycemic. They aren't able to produce insulin, so they're always going to appear hyper, and it's going to be very high, 300, 500, 600, something like that. 2 is going to be progressive, so our patient that is older. Again, they have the polyuria, polydipsia, and we see other disorders in coordination with type 2 diabetes many times. So it can be the patient that as high cholesterol, high blood pressure, obesity, a sedentary lifestyle. If we think about the American Diabetic Association, they say that our hemoglobin A1C should be 6.5 or lower. So with our patients with type 2, we're going to see them that are going to be 7, 8, 9, 10, 11, and also their finger stick being 126 or higher. We think 100 to 125 is kind of that pre-diabetic fasting, and then greater than 126 fasting. They usually say on 2 separate occasions, indicating that if they're fasting, that they could have diabetes. And then we would do a hemoglobin A1C to look at the period over a 3 to 4 month period to say, what has that average level been for our patient? So also thinking about what kinds of things increase or decrease blood glucose, and how do we regulate insulin with that, or any kind of medication. So when we exercise, we're going to be burning more of our fuel. If we are exercising and we are, let's say we're taking insulin, those patients may need lower doses of insulin when they're exercising because they're going to be burning more of that. We want to make sure that patients are using medications as directed. We'll, talk about different types of insulin and why we would need those. But in addition to that, they are getting exercise and a diet that is low in carbohydrates, because our ideal is that we want to reduce the amount of insulin that our body needs. Hypoglycemia is equally important. We need a blood sugar that is greater than 70. We start to see problems that affect the brain if our blood sugar gets below 30. But that doesn't mean that we're not going to see a person that's confused with a blood sugar less than 70. Many patients that are diabetic, they know when their blood sugar is getting low. Common signs are going to be that they're pale, they're confused, they're diaphoretic, they're a little clammy and shaky, and they may or may not be able to focus on you and communicate with you. So if we think about with hypoglycemia, we need to replace glucose. If they are alert and oriented, able to swallow and able to communicate, that's also going to say, can we give them something oral to take, or is it unsafe to do that? So we could give them complex carbohydrates, simple carbohydrates. We could give them glucose tablets, and then if they are not able to take anything oral, we could give them D50, and that could be given IM or IV. And every facility has a policy about kind of the steps that you take and what blood sugar. Many times if you get a blood sugar that's out of range, below 70, they're going to want you to retake that before you treat that patient. Okay, so if we don't have insulin in the body, we're going to be hyperglycemic because insulin opens the doors of the cell to let the glucose in. We're also going to have polyuria. The body is saying that we have too much sugar in our vascular system and we need to get rid of it. So we're going to be peeing that out. Okay. Polydipsia, we're going to be thirsty. Polyphagia, it's going to make us hungry because the cells are kind of starving. They can't get the sugar in. We could also have what's called ketone bodies. So if we don't have sugar that we burn for energy, we can't get glucose in, what our body does is it burns fat. And as a result of burning fat, we make a byproduct called ketone bodies, and it forms an acid called ketotic acid. Signs of that ketotic acid mean that we don't have insulin. So patients that are showing ketones, their blood sugar is going to be really, really high. Okay. The blood's also, it says hemoconcentrated. Hemo meaning the blood's really concentrated. Lots of sugar makes the blood thick and syrupy. Low blood volume because we're peeing all our fluid out. Hyperviscosity means it's very thick. And low perfusion because I'm peeing out all my fluid. And if I'm peeing out all my fluid, I'm not going to be able to have a lot of fluid volume in the vascular system to pick up oxygen, so we can see signs of hypoxia as well. Okay? When patients make that ketotic acid from those ketones, they can go into acidosis, a metabolic acidosis. This is most commonly seen in type 1 because type 2 still can make insulin, so they're not going to burn ketones. They're still going to be able to get some glucose in the cells. So type 1 are at risk of metabolic acidosis. And as another way our body treats the acidosis, if it's metabolic, our compensatory mechanism is that the lungs are going to help out. And they try to blow off acid, and we see these things called Kussmaul respirations, where the expiratory rate is longer than the inspiratory, and it's involuntary. And again, our respiratory system is trying to compensate for that respiratory or that metabolic acidosis by blowing off acid. Hemoglobin A1C levels, we should be less than 6.5. So again, looking at our patient's hemoglobin A1C level can help us to say initially, are they truly diabetic for the past 3 to 4 months? Has their blood glucose been elevated? This isn't an isolated event where they actually did eat or drink before we drew their blood. And then we can also use it to compare with our treatment to say, is their hemoglobin A1C getting better or worse or staying the same? Hemoglobin A1C is where our body is helping to transport that glucose around, and it has to do with our hemoglobin. And so hemoglobin, red blood cells last about 90 days. And so that's what we're looking at, is the hemoglobin, that proteins attached to the hemoglobin to see what their glucose levels have been. Oral anti-diabetic agents, only type 2 can take oral diabetic because they're not insulin. And they just help our body in other ways to utilize insulin, or to stimulate insulin. In type 1, they will not be effective, so they can't use it. Usually patients on oral anti-diabetic meds, they have a diagnosis of less than 5 years, simply because the longer we are diabetic, the more progressive the damage to the beta cells are. So our patients who are type 2 may eventually be insulin dependent because the beta cells stop working. And if that's the case, then they're going to need insulin, not oral diabetic meds. Fasting blood glucose, less than or equal to 200. So again, if their fasting glucose is sky high, they're not making any insulin. So these medicines aren't going to help. Less than 40 units of insulin a day, again, they are still making some insulin. And then normal kidney and liver function, because these medications have to do with metabolism and excretion of glucose and things that are going on in our body. And the byproducts can be hard on your kidney and liver. Couple different kinds of oral diabetics. We have the alpha glucoside inhibitors. They decrease glucose absorption in the small intestine. The thiazolidinidines, they increase the peripheral glucose uptake. So they allow the cells to take in more glucose. Again, they're helping insulin. And then the sulfonylureas and megalotines, they increase insulin secretion from the pancreas. So they are stimulating the beta cells to hopefully do more. And then the biguanides, and they are decreasing hepatic glucose output. So they are having the liver, preventing it from releasing glucose. And sometimes that can be our problem, is that the liver is not functioning well, and so it's spilling out glucose. So again, it's working in many different ways other than replacing insulin, because it's not an insulin replacement. This is an example of a sliding scale. They're different for different patients. Anymore, you won't look at a scale. The physician will write down, based on the glucose of that particular patient, how much insulin that they want them to have. And this is, again, based on finger stick blood glucose levels. Okay? Glucose can be rapid acting, short acting, intermediate acting, and long acting. And so they have two different purposes. Rapid acting and short acting are going to replace insulin that, they are going to replace insulin that we need at mealtime. Okay, so we take rapid acting and short acting when we do a finger stick blood glucose before meals and at bedtime. If our blood sugar is elevated, then we supplement with a certain amount of rapid acting or short acting. So that has one purpose, is to regulate glucose at mealtime. Intermediate acting and long acting are going to be our continuous levels. So during the day, our body naturally releases a continuous amount of insulin to regulate the glucose that our body is naturally releasing from the liver. Immediate and long acting are going to be given scheduled either once a day or twice a day. And they are, again, going to be released either, when they say immediate, is going to be usually every 12 hours, it's going to need another dose, or long acting is many times once a day. They are for patients who have good glucose control. And what I mean by that is, if my glucose is up and down and all over the place, I'm more likely to be checking my blood sugar more frequently and then responding to that level by using a rapid acting or short acting to correct it during the day. If I have good glucose control and I know how much insulin my body needs to level it out continuously, then I'm more likely to be on the intermediate or short acting. So some of our patients may be on both of those. But then again, if our patient has good glucose control and is on an intermediate twice a day or long acting once a day, when they check their blood glucose before meals, if it's normal, then they don't need the rapid acting or short acting. So if our patients come into the hospital, what we tend to do is we add on more rapid acting or short acting, because due to illness or infection or injury, the body is utilizing that stress hormone and releasing more glucose. Due to any kind of stress, physical, emotional, and so patients are more likely to have increased glucose levels in the hospital. So our patients may even say, I don't use this kind of insulin, or I don't even take insulin, and they're afraid they're going to get addicted to it. So we need to explain to them that due to their disease process, they had a heart attack, if they have an infection, if they're repairing from some type of surgery, then their body's naturally making more glucose. And if we check it throughout the day and it's elevated, increased glucose is going to prevent them from healing properly. So we need to pull it into the cells. So it may be different while they're in the hospital. It may even be different when they go home. So we need to educate them about that. Complications of hyperglycemia can be macrovascular, which are large blood vessels, or small blood vessels. Macrovascular, we think about the heart, and we think about the blood vessels. So I have a risk of having a heart attack or a stroke, because if it has to do with the blood vessels, then it can cause inflammation on the inside of the blood vessels, and blood clots can happen. Okay, so I can either have a blood clot that goes in the coronary arteries to the heart, or a blood clot that goes to the brain and causes a stroke. The very small blood vessels can also become very inflamed. And so we see many times symptoms in those microvascular, very small blood vessels first, because they are so tiny, and they get inflammation, they get occluded more quickly. So things like vision problems, diabetic neuropathy, which is blood vessels that are very distal to our body, and so they take blood flow to places like our feet. And if those tissues are damaged, then they also can't receive information from the nerves. So we get numbness and tingling. Patients are at risk of not having good wound healing on those distal extremities, so they have sores that won't heal, at risk for amputations. Diabetic nephropathy, that's the kidneys. Small blood vessels that feed the kidneys. If the kidney's not fed with oxygen and glucose, then it starts to malfunction. So we see problems with kidney failure. Patients that are Diabetic, hyperglycemic can also have so much kidney damage that they have to be on dialysis. And then also erectile dysfunction. So people will say that, again, the small blood vessels that take blood to the penis aren't able to get blood flow. So that could be a complaint of our patients as well. So when our body needs insulin, we need more insulin when our body is making more glucose. So I want you to think about physical stress, emotional stress. Our body is fighting infection. It's healing from a surgery. We have a high fever. We are recovering from an illness. We're making more glucose, releasing it from the liver. We need more insulin. We need less insulin when we're burning more sugar. So when we are exercising opens up the cells and allows glucose to enter the cells. So we're using it more efficiently. Okay, sick day rules. I know that was one of the things on the checklist that we had. Diabetic sick day rules. We want to prevent losing a lot of fluid. So if we have diarrhea or vomiting, again, that could cause problems with fluid balance. And could cause our patient to have signs of dehydration. We'll talk about why that's important for a minute. When they're sick, we want to replace fluids, okay, even if it's small, frequent amounts of fluids. Fluids are needed in the body to carry insulin and to get glucose into the cells. We want them to continue eating very small amounts, even if they can't hold it down. Don't eat big meals, eat small amounts. Treat the nausea, again, treat diarrhea, treat nausea, prevent them from losing fluid. Rest and avoid exertion. Frequent blood sugar monitoring, but we're also going to monitor the urine, and that's where checking ketones comes in. Remember, we said ketones were going to be if we were not able to get glucose into the cells, and we are burning fat instead of sugar, and so we're going to make that ketotic acid. So anytime a patient is ill, we have them check their urine for ketones. If it's positive, they need to get to the hospital. It means that their glucose levels are really, really high as well. And we need to be able to give them insulin to be able to open up those cells to use their glucose. Give their scheduled insulin. And we think, well, if I'm not eating, should I take my insulin? And this is what patients do. If they're sick, if they're not eating as much, they don't take their insulin. But what happens is the liver is still going to release the glucose and it's not going to go in the cells. So that's why we monitor blood sugar frequently. We tell them to take their insulin, monitor their blood sugar. That's why they need to continue to eat a little bit. They may even need extra insulin, so they don't be shocked if their blood sugar is higher than usual, because again, we might be losing fluid again, which is going to make the glucose kind of the blood thicker in that. And if we have low blood volume, we're not able to get insulin around as we usually do. So extra insulin, because the liver is releasing that glucose, it's a stress response, and we need insulin to take it into the cells. And then know when to call the doctor. They should have a parameter of if there's ketones in their urine, call the doctor or go to the doctor's office. If they can't hold fluids down, if their blood sugars are above a certain amount. So making sure that they understand about glucose insulin, and continuing to take their medication even if they're sick, because instead of low blood sugar from not eating, they're going to have high blood sugar from that stress response of the body. So diabetic ketoacidosis and HHNS. Diabetic ketoacidosis is what we see with type 1 diabetes, okay? It's life-threatening. Glucose, it says over 300. It can be over 500, 600. And it's where we are burning fat for energy because we don't have enough insulin to open the cells to get glucose in it. And so due to that burning of those fats, we make ketotic acid. It can happen very quickly. And then that acid, when it builds up, it will be positive in the urine because our body is trying to get rid of that. It usually goes with dehydration and electrolyte loss. Think about it. If we don't have insulin to open the cells, all that glucose is spilling out into the blood, it's circulating, and what happens is the kidneys want to get rid of it. So we start peeing a whole lot. We have electrolyte imbalances, dehydration, okay? We can have metabolic acidosis. And it's caused by that lack of insulin, the ketones breaking down, causing us to urinate a whole lot. Buildup of ketotic acid can cause kind of a fruity breath, kind of like a sweet breath on a patient. And we're going to see those Kushmal respirations as a response to a compensatory mechanism of metabolic acidosis. The lungs are now trying to get rid of acid, get rid of CO2, and they are hyperventilating, having those long expiratory phases. pH will be low, we said, because they're going to be acidotic. Sodium levels will be higher. We're losing fluid, okay? Decreased potassium related to diuresis, so we could also be losing some potassium as well. Okay? So again, we're going to show electrolyte imbalances, but we've got to replace the fluid before we treat the electrolyte imbalance. So we would replace the fluid very quickly. We would give them insulin, usually would be IV, and then we would continue to be monitoring their glucose, monitoring their lab work, and then we would then look at electrolyte levels. Again, diabetic ketoacidosis. They need hydration, so they need fluids. They need insulin to open the cells, and then we do electrolyte replacement. HHNS, or it's a hyperglycemic hyperosmotic state, or sometimes it's hyperglycemic hyperosmolar non-ketotic state. And non-ketotic, it's type 2. So our type 2 patients, we are having patients who have very high glucose levels. This many times results because the patient has dehydration, or it can even cause dehydration. It's most common in patients who either, number one, don't recognize that they're thirsty, so problems with cognition, problems physically being able to get themselves something to drink or eat, or it could be patients who have problems with communication. So we think about elderly patients. Glucose is very high. It becomes hyperosmolar, which means very thick and syrupy blood, and it leads to us peeing a whole lot. Okay, no ketones because we are still able to produce some insulin. So glucose is getting in the cells. We're able to use it for fuel. And if it's left untreated, those patients are going to die from dehydration. They're going to pee and pee and pee. Let's see, inadequate fluid leads to dehydration, decreased kidney function because it's not getting enough cardiac output to get oxygen to the kidneys. Infection, stress, medications, lots of things can cause HHNS, but continually losing that fluid is going to be what the problem is. Their pH is going to be normal because they're going to be in a dehydration state, not an electrolyte imbalance. It's not going to be a problem of making acid or anything like that. So we've got this question. Student asked why the patient is breathing so rapidly and deeply. What's the nurse's best response? Okay. Think about if we're breathing rapidly, then usually it's a respiratory problem. And so if it's respiratory, it could be acidosis. So serum pH is low from acidosis. Again, we don't know if the respiratory rate is low, that would be because our body is having some problem with respiratory and they're holding on to too much CO2. In the ED, the patient is diagnosed with diabetic ketoacidosis. What's the nurse's first priority for this patient? It's going to be airway, of course. So we think about, replacing fluids, all those kind of things. But remember, if our patient is high glucose and peeing, we're worried about cardiac output. Anything with fluid is cardiac output. And so making sure that airway, breathing, circulation is important. 20 minutes later, the patient is admitted to the ICU for DKA. Again, when you think about DKA, think about and that they don't produce insulin, so they're going to burn fat, they're going to make ketotic acid. Patient is receiving IV regular insulin, so we can get glucose in the cells, with frequent finger sticks to check glucose level. Potassium level is 2.5, and IV potassium supplements have been ordered. So potassium is low because what happens is when we are peeing, we're going to be pulling that glucose from the cells into the vascular system, and then that's going to go to the kidneys, and we're going to be getting rid of that as well. So what assessment must be made before giving the IV potassium? Again, before correcting electrolytes, we are going to be checking for fluid balance. And it could be looking at blood levels, it could be looking at urine output. So if we don't have urine output of at least 30 mLs an hour, that means the kidneys aren't getting enough oxygen, and we're still showing some signs of low fluid volume, low cardiac output. Which symptom requires immediate intervention during a hypoglycemic episode? Think about confusion, so that's lack of oxygen to the brain. We would want to make sure, again, that we were correcting that by replacing glucose. When should a patient with type 1 diabetes avoid exercise? Again, that is when the ketones are present in the urine. What that means is that this patient is, their glucose is high in their blood, but they can't get it into their cells. So if we're exercising, we are burning more glucose in the cells, and we already are not able to get into the cells. So those high ketones tell us that we need insulin. Clinical manifestations of hyperthyroid. Remember, everything's speeded up. So it could be increased appetite, that eyelid retraction, that exophthalmos, insomnia, palpitations, tremors. Those are the things. Cold intolerance, constipation, and weight gain are going to be hypothyroid. Which urine properties indicate to the nurse that the client with SIADH is responding to interventions? So what that means is, remember, SIADH, we're holding on to fluids, okay? So if we are responding, then what are we going to see that shows we're losing fluids like we should be? So we should have increased urine output, right? I think I marked the wrong answer on this. So showing that SIADH is responding, that means we're going to be peeing more, okay? So ignore my answer down there. We're going to be peeing more, and our specific gravity is going to be decreased, because we said with SIADH, we were peeing very little and it was very concentrated. So another thing with these questions too, you have to really read and say, is it asking me about the disorder, or is it asking me about what are signs that it's getting better? And so it's going to be the opposite of that. What is a possible outcome for the patient experiencing an age-related decrease in antidiuretic hormone? So if we have low antidiuretic hormone, we're going to have diabetes insipidus, right? So signs of that are going to be dilute urine and dehydration. Now, I think what the question is saying, it doesn't mean that they have diabetes insipidus, but it means that they are low on antidiuretic hormone, not to the extent that they're having problems with diabetes insipidus, but as related to age, we don't make as much antidiuretic hormone. So we get rid of more dilute urine, and we have higher risk of dehydration. Any questions, guys? Okay. I have, and I'm going to show you this. At the very bottom, with practice questions, and I will publish this. I've got the final review questions from, this was, what it was 120, that was 125. So it's got about 120 questions and it includes everything. We'll put links on here to online quizzes. Some of them have like up to 100 questions. And so they're GI, they're renal, they're endocrine, and they're really good questions, and it's got the rationale. The final review questions on here, I did not upload the answers, but I will do that tonight so that you can read over and review, and so it doesn't have the answers on there. You can kind of quiz yourself and then go look at the answers. Any other questions? Okay, guys, well, I really appreciate you hanging out with me tonight.
Thank you for all your help.
You are very welcome. So I think that those PowerPoints will be helpful as well. When is your test?
A week from tomorrow.
Okay, good. So we've got next Tuesday as well. So next Tuesday I can kind of look at renal and GI or answer any other questions that you've got as well. Okay, guys, have a good night.
Thank you.